Thank you for joining me today. In this video, I have a 5 clinical case study that will help you make a clinical based decision making. In this video, you will learn how to differentiate complex psychiatric diagnosis using a targeted history and medical response. You will apply evidence-based psychiatric psychopharmacology strategy to treat persistent and high risky cases. You will identify medication advice effect as a diagnostic and treatment guiding clues. You will develop a safe, patient-centered medication plans across the diverse population. You will integrate, monitor, describe, and risk-benefit analysis into psychiatric care. Our first clinical case study is 47 years old patient with major depression disorder. Responses partially with Zoloft or other name sertraline, and it is 150 milligram, and also this patient is taking a escitalopram 20 milligram trials over the past 3 years. Mood improved mildly, but persistent fatigue. So the patient still have a persistent fatigue, diminished motivation, sadness, and cognitive slowing remains. No manic history. Depression scale, which is PHQ-9, is 14. That is depression. Assessment. Meeting the criteria for treatment, persistent depression is equal to or greater than 2 adequate antidepressant trials. So this patient already had 2 medication trial, 2 antidepressant medication trial, and still has that residual symptoms will suggest a dopaminic or noradrenergic deficit rather than serotonic failure alone. So the plan is continue SSRIs, and you will add bupropion, extended release 50 milligram daily, and increase as tolerated. You will monitor the blood pressure, anxiety activations, and insomnia. You will monitor those. You will encourage the behavior actions, and clinical morals are after 2 failed treats agreement rather than rapidly switching the medication. So you will, because the patient is responding the medication partially, you will add other medication instead of switching. You will watch residue symptoms to neurotransmitter targets. Our second clinical case study is adult with ADHD versus anxiety. So this patient is 34 years old and reports chronic distractivity, forgetfulness, poor task completion since childhood. Anxiety is worsened after SSRIs initiated. So the anxiety gets worse after the patient had that medication is SSRIs, and reports relief when deadline is enforced. So the patient is scared of the tasks. No panic attacks prior to age 30. Assessment revealed the development history supports ADHD with secondary anxiety, not primary general anxiety disorder. The plan is starting aromoxetine of 40 milligram daily and titrate slowly as tolerated. You will monitor the blood pressure, heart rate, and mood. You will provide psychoeducation on ADHD-related anxiety, and clinical photos are lifelong symptoms favor ADHD, treatment attention after reduces the anxiety. Our third clinical case study is a bipolar. It's 42 years old with recurrent depression, develops agitation, rising thoughts, insomnia on multiple SSRIs. And this patient has a history of paucity for bipolar disorder. When you assist the patient, you notice that a recurrent antidepressant activation plus family history of bipolar 2 disorder. Your plan will be discontinue the SSRI and initiate lamotrigine slowly titration. You will monitor mood, bipolarity, mood bipolar, and clinical oral is antidepressant. Sensitivity often signals bipolarity. Avoid antidepressant monotherapy. Our fourth clinical case study is antipsychiatric associated with metabolic syndrome. This patient is with schizoaffective disorder and gained 40 pounds on olanzapine. When you check the A1C, it increased to 6.7%. Patient reported sedation and decreased activity. After you assist the patient, you realize that the metabolic risks outweigh the benefit at the current dose. Then you plan cross taper to aripiprazole, and you coordinate PCP care for glucose and lipid monitoring. You begin lifestyle counseling, and the clinical bureau is the psychiatric stability include a physical health. Weight gain affects the adhesiveness. I have seen some people who come to the hospital, and when you ask them what was the reason you didn't take your medication, they will say, I have been gaining a lot of weight, I have been fatigued. They will tell you the symptoms and the reason is why they stopped taking this medication. So that is why you have to pay attention to the patient symptoms, outcomes, compliance, and the reason that they stopped or they want to stop. Our 50 clinical case studies, the lithium use in a renal risk. We have a 68 years old with bipolar 1 on a lithium for 20 years. And EGFR decreased to 48. That is lower. Lithium level is 1.0 mEGL liter. After you assist the patient, lithium is still effective, but supratherapeutic for age and the renal function. Your plan is to reduce the dose to target lithium level 0.6 to 0.8. You will monitor renal and thyroid labs every 3 months to 6 months. And the clinical moral here is the lithium is not automatically contraindicated. Lower levels remain effective in older adults because this medication, lithium is controlling the symptoms of the bipolar, but the patient has decreased kidney function, so you have to decrease the dose. Our clinical case study number 6 is benzodiazepine deprescribing. So we have a 5 years old on a clonazepam, 1 milligram nightly, and time is 15 years for insomnia and anxiety. Patient reports failures and memory decline. So the child reports to you failures, he been failing or she been failing, and their memory is declining. When you assist, you realize that dependency present and risky outweigh the benefit. Your plan is to slow taper to 5 to 10% every 2 weeks to 4 weeks, and then you will start SSRIs, and also you will begin or refer to cognitive behavior therapy. Clinical photos are describing is active treatment, slow, equally safe. That is the lesson to learn from this case study. Our 7 clinical case study is 27 years old, 28 years old, 6 weeks postpartum with crying, spells, guilty, insomnia, low appetite. Wow, that's depression. Despite to breastfeeding. So she's still breastfeeding, but she also has those symptoms. After you treat the patient, you realize that there is a moderate severe postpartum depression. Your plan is to start sertraline and refer therapy, or you can do the therapy. You will monitor the infant exposure, and the clinical borrow or the lesson to learn from this case is untreated maternal depression carries a great risk than medication. Sterling preferred in lactation. So this medication is good with the lactation. Our 8th clinical case study is 25 years old female on Raspadol, and she reports amenorrhea and coheria, but assumed it was stress. After you assist the patient, you find out that dopamine D2 blocker induced the hyperlactemia. Your plan is add or switch to aripiprazole and monitor prolactin and the symptoms. Clinical role here is the patient rarely volunteer menstrual changes and always ask it directly. So you have to directly ask them if they are having a menstrual changes. Our clinical case study number 9 is a depression-related insomnia. We have a 50 years old on a SSRI with early morning weakness and slow energy. After you assess the patient, you realize that they have a sleep disturbance secondary to the depression. Your plan is to add mirtazapine or trazodone for sleep to improve the sleep. That will reinforce the sleep hygiene. And lesson to learn from here, or this case study, is treat the underlying mood disorder. Hypnotic alone rarely resolves the depression-related insomnia. Because if you have a depression, only sleep medication won't help, so you have to treat both. Our clinical case study number 10 is a 78 years old with depression and baseline QTC of 75 minutes. After you assist the patient, you learn that high risk with QT prolonging anti-depression medication. So some of the anti-depression medications will cause QT prolongation that will lead to heart failure. So your treatment plan is to choose sertraline, avoid citalopram because that is one of the medication that prolongs QT. And lesson to learn from this case study is QT risk is irreversible unless monitored. Medication choice saves lives. Yes, that's true.